Welcome once again into the Radiopaedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me, ready to dish out more goats and anecdotes and works of young adult fiction, it's my co-host Frank Gaylard.
Goats I can do, Dixon. Young adult fiction. That sounds wrong if you say too much of a pause between young and adult, right? Young adult fiction. That is definitely not what I was writing. It was young adult fiction.
So no book deal as of yet, Gaylard. That's
I
what
haven't
it sounds
received
like.
any calls yet. No, it's disappointing.
We did receive a lot of positive feedback about last episode.
Oh, excellent.
I'm not sure how much of that was in reference to your writing skill, though.
I was really struck by just how good Kate made it sound and how much better she made it sound than you did, I guess.
You already said that. You're repeating old material.
But it did remind me of, I can really remember the moment when I realized just how important and skilled a good narrator is and how much they influence your appreciation of a book. Because I listen to audiobooks a lot. There was a book that I loved listening to. I still say reading because I think the experience is quite similar. But anyway, I listened to The Amazing Adventures of Cavalier and Clay. That's a Michael Chabon, I think it's how it's pronounced. This great big story of two young gay Jewish guys who start publishing comics in New York before the Second World War, I think, from memory. Anyway, it's an amazing, like a really, it won a Pulitzer Prize or something. It's a fantastic book. And it's just the kind of book that I think my wife would like. So I recommended it to her. And then it sat there for a while and I saw that she was never, I said, you don't enjoy it. She went, to tell you the truth, I can't read it. I can't make heads or tails of what the hell he's talking about. And I was like, what do you mean? And I opened it and each page is just a rectangle of text. His sentences are half a page long with commas and semicolons and parenthetical statements, and the prose is all really dense and condensed. And I tried to read it on paper and it's like, you're right, I can't understand what the hell's going on. But the person who narrated it was able to, through pauses and inflection, add all that comprehension that was just missing from the page. It was a moment where I thought, wow, a narrator makes an enormous difference.
You listen to things at like 1.5 or 2 times speed, right? So do you favor narrators with low-pitched voices so that when they're sped up, they become down to a normal pitch?
Yes, very funny. They get pitch corrected, so they're not a thing. But yeah, I do listen usually somewhere between 1.7 and 2.5. And the reason for that is that they speak really slowly. And at that speed, my brain just wanders. I can't focus. And I notice then that I haven't been paying attention. Whereas if
I
you
understand this entirely because Murph speeds you up to 1.7 every week in the edit.
Yeah, absolutely. I know I speak quite slowly.
No, you're good. Hey, I'm listening, while we're talking about this, I'm listening to a book called Project Hail Mary right now. Amazing audiobook. I think it's Ray Porter who reads it. And no spoilers, Gaylard, if you've read that book.
I have.
It's by the same author as The Martian. What's his name? Andy Weir.
Yeah, I have read it, but I don't think I could spoil it, even if I tried, because for the life of me, I can't remember anything about it.
Little astrophage depleting the sun's energy. First contact with an intelligent alien being. Ring any bells?
Yeah.
If you can't remember, it's not a great sign, is it, for the rest of the book? The first half was good anyway.
Yeah, it does ring a bell, but I still couldn't spoil it for you, though. While we're doing book recommendations, though, Dixon, I know we've been banging on a bit. But I'm
going to have to change the intro to the podcast because it says unconcerned with books or poetry.
I'm rereading the Expanse series. It's been made into a TV show, which I refuse to watch because it always spoils the book. But it's a science fiction series by James Corey, I think is the author. It's finally finished. It's 9 books. The 9th book got published, I think, a year or 2 ago. And I'd only read the first 4 years ago, so I started again. And boy, it's great. It's so much fun. So if you're looking for a quick 9-book series, each book they're about 18 hours to listen to, so they're pretty thick. But, it's not 18 by the time you speed it up.
Speaking of a good series, the new series of The Boys is out. Have you started watching that yet?
Yeah, I'm watching it with the kids, so we're rewatching
really?
it.
There's some scenes maybe you might not want to watch with the
Yeah,
kids.
we've already burnt that bridge quite a long time ago.
All right, let's talk about today's episode. In fact, actually, before we talk about that, we have a little follow-up from a prior episode.
Okay.
We need to announce the winner of the Radiopaedia 2024 virtual conference registration from our Stay Rad song contest that we did.
Oh, yes.
The conference is less than 2 weeks away, so we really need to announce a winner. And that winner is randomly selected, Raphael Ambros.
Congratulations, Raphael.
Yeah. And he's a deserving winner, Gaylard, because I looked at his account on Radiopaedia and he's been a supporter for quite a number of years. So that's
thank you,
great.
Raphael. Thank you very much.
And now he's going to be hooked up with free registration for the conference.
Excellent.
And in terms of the song,
yes, which one won?
Winner, I'm going to save that for our next episode, Gaylard, because next episode's our special 2-hour podcast.
You're such
at the actual conference,
Dixon.
No, because we'll need filler content. We've got to go for 2 hours.
2 hours is no problem. A few goats, a few book reviews, a few AI generated songs, and then all you need to do is slow me down to 0.9.
I'll say this. Raphael voted for These Are My Machines.
Good choice.
That doesn't necessarily mean that that's the winner. You'll have to stay tuned until next episode to find out. All right. Now, today's episode, Gaylard, requires a little explanation as well. So we've been very busy recording things and arranging things for the upcoming conference. So we thought no better time than now to try out a minimal viable product segment idea for the podcast. And that idea is solo readful.
It's a minimum effort.
So just one of us reading a Radiopaedia article on our own as the main segment. So you, Frank, kindly offered to do the first one.
Yep, that's me.
You sent it to me, and the content was great, but there was one little problem. There was so much echo that it sounded like you're in a church hall.
I actually recorded it in a monastic retreat high in the Himalayas where I was communing with God.
I'm sure you were. Or goats.
Well, I was pretty close. I was on a 2-day Frankation, just me, the dog, and I guess my chainsaw, because that's what I spend most of my time down there, chopping trees.
Well, I didn't hear any dogs or chainsaws or goats. I just heard an overly ethereal Gaylard in the recording. Anyway, you needn't worry, sir, because you know what? I never let our listeners down, Gaylard. So this morning, I recorded my own little solo readful to play as the main segment.
You're a good man. The thing that annoyed me most about my attempt, and I think actually it worked quite well as well, but the thing that annoyed me most, because I was down at the beach house, I couldn't find my headphones. And so I did a test just on my laptop, and then I listened to the speakers and it sounded okay. And so then I did the whole recording, and then I edited the whole recording, and then I sent it to you, and then you sent it back, and then I found my headphones, and it's like, oh, this is terrible. And if only I'd spent a bit more time looking for my headphones, I would have saved. I could have spent an hour and a half looking for my headphones and still come out way ahead on the whole enterprise.
Anyway, that's okay. You'll be able to record it again sometime.
No, and I think it'll be good actually, because it'll coincide with my next learning pathway, which I've finally finished, but won't be coming out until after the conference. So we'll make it match up with that.
Good idea. So the topic I chose to record today, Gaylard, was diffuse idiopathic skeletal hyperostosis, so DISH.
And that's why you said dish in the intro. I thought for once you'd finally done one without a pun.
Yeah, nah, it was a clever one.
Very, very snuck in.
So why diffuse idiopathic skeletal hyperostosis, I hear you ask, Gaylard? Well, I was pre-listening to Matt Skalsky's MSK calcifications lecture for the conference, which comes in at a lazy 85 minutes, by the way. And that's at 1.7 speed. No, that's at normal speed. And he mentioned that people often forget that DISH is not just a condition affecting the spine, but it also causes enthesophytes elsewhere. So that inspired me to do a little update on the Radiopaedia article this morning, and then I went on and recorded myself reading it.
Excellent. That's about as good a method for choosing an article as any other.
Yes. The path of least resistance.
We need one of those topic Wheel of Fortune.
It's not a bad idea.
Where you just spin it and it just starts you randomly.
Let me hit play now on my recording. Frank, you'll need to put your listening ears on. You got your good headphones, or you're just listening through your computer speaker? And then we'll be back for another chat in the outro. All right, here we go. On my own. This is fantastic. I should do this without Gaylard more often. I've just spent the last hour or two editing and updating the Radiopaedia article on diffuse idiopathic skeletal hyperostosis. So I thought I might read that article out to you as a bit of a solo readful episode. So we'll get into it. Diffuse idiopathic skeletal hyperostosis, DISH, also known as Forestia disease, is a common condition characterized by bony proliferation at sites of tendinous and ligamentous insertion. It primarily affects the spine of older individuals. On imaging, it manifests as flowing, bridging anterior vertebral osteophytes, most prominent in the thoracic spine, and enthesopathy, particularly around the pelvis. The presence of flowing anterior ossification spanning at least 4 vertebral levels with preserved disc spaces is often used to define the disease. There you go. That's the opening paragraph. I only made a few little changes to that, in particular, trying to emphasize the fact that it's not just a spinal condition, there's also enthesopathy elsewhere in the body, particularly around the pelvis. Let's move on to epidemiology. DISH most commonly affects the elderly, especially in the 6th to 7th decades. The estimated frequency in the elderly is around 10%, with a male predominance. The prevalence appears higher in developed countries. Associations. I made a few little changes here. So, recognized associations include ossification of the posterior longitudinal ligament. So, this accompanies around 50% of cervical cases of diffuse idiopathic skeletal hyperostosis. The next association is metabolic syndrome, obesity, and diabetes. And this is almost certainly why the prevalence is higher in developed countries. And then the third association, which I added in today, is ossification of the stylohyoid ligament and Eagle syndrome. So, DISH and ankylosing spondylitis patients both have a measurably longer styloid process than controls. So, not everyone with DISH has Eagle syndrome. It's actually still very, very uncommon, but there is this interesting association between these conditions. These people tend to just be able to make more bone around their body than other people. And I thought this would be interesting because Gaylard will probably tell a story about his own stylohyoid ligaments for us in the discussion. I actually removed an association here. Previously, our article said that 1/3 of patients with DISH have HLA-B27 in association. However, I think more recent data shows it's around 8%, and that kind of matches the background prevalence of this antigen. So I've removed the HLA-B27 association. All right, let's move on to the clinical presentation. So, DISH is often identified as an incidental finding when imaging for other reasons. However, spine stiffness and decreased mobility, similar to ankylosing spondylitis, may be a presenting complaint. In the cervical spine, dysphagia may occur from direct impression upon the hypopharynx and upper esophagus. Spinal fractures, often even following low impact trauma, may be a presenting scenario. Yeah, I think we all know that we see this mainly as an incidental finding, but we need to think about it, particularly in trauma patients, and look hard for injuries. We'll come back to that later. We've all probably also seen quite chunky osteophytes from DISH in the cervical spine, displacing that upper aerodigestive tract anteriorly. All right, moving on to pathology. The etiology of DISH is still unknown, but likely involves an imbalance of growth factors and inhibitors leading to excessive bone formation. Histopathological features of spinal DISH include focal and diffuse calcification and ossification of the anterior longitudinal ligament, ossification of the paraspinal connective tissue and annulus fibrosus, degeneration of the peripheral annulus fibrosus fibers, anterolateral extensions of fibrous tissue, hypervascularity, chronic inflammatory cellular infiltrate, and finally, periosteal new bone formation on the anterior surface of the vertebral bodies. I added in this new part here today, which says the rate at which the ossification progresses is reported to be around 1 vertebral space bridged every 10 years. And in fact, that's a similar rate to how ankylosing spondylitis progresses untreated. The bone outgrowth begins at the anterior vertebral body above and below the intervertebral disc, rather than commencing at the end plates like degenerative disc disease or within the annulus itself, which is what ankylosing spondylitis tends to do. I've also added in a section here on location just because it wasn't very clearly stated previously. So, location, the thoracic spine is the most common, and usually they're right anterolateral flowing ossifications, particularly from the T7 to the T11 levels. It seems that the descending aortic pulsation prevents it from occurring on the left hand side. And this is confirmed in patients with situs inversus, where they have the opposite finding. They have left anterolateral ossifications when they have DISH. The next most common site is the cervical spine. The ossifications there are located directly anteriorly. There's no left or right predominance, and it's maximal at the lower half of the vertebral bodies. And we'll come back to some signs associated with this later. The lumbar spine is less commonly involved, and really, when you're seeing it in the lumbar spine, that implies you've got very advanced and late disease that you're seeing. The next location is the sacroiliac joints, and in the sacroiliac joints, you typically have these bridging osteophytes located at the anterior aspect of the joint. And then finally, we have extraspinal locations and thesophytes around the pelvis, knee, elbow, and ankle. Again, we'll come back to these. Moving on now to the radiographic features, and I've expanded this quite a bit, particularly looking at the criteria. So it begins like this. The Resnick and Niwayama criteria remain the most widely used in the imaging diagnosis of DISH, requiring, and then there's 4 things that this criteria require: flowing osteophytes over at least 4 contiguous vertebrae of the thoracic spine. The next one is preservation of intervertebral disc space without extensive degenerative intervertebral disease. The next one is absence of facet and costovertebral joint ankylosis. And the final one is absence of sacroiliac joint erosion, sclerosis, or fusion. So what we're saying here in this criteria is basically you've got these flowing osteophytes over at least 4 levels, and they haven't really got background disc degenerative disease. They haven't really got features of ankylosing spondylitis. So they haven't got ankylosed facet joints or costovertebral joints. They haven't got ankylosed or eroded sacroiliac joints. I've added another little comment here, and it goes, this, however, essentially represents end-stage DISH, and others have suggested using a vertebral span of 3 or even 2 levels in the setting of prominent extraspinal enthesopathy. So yeah, I think if you start seeing prominent enthesophytes around the pelvis, around the knee, around the elbow, ankle, and then you've also got these flowing osteophytes over just 2 contiguous levels in the spine, most people would accept that as most likely being diffuse idiopathic skeletal hyperostosis. Moving on to the next section, which is plain radiograph and CT. And we've broken this down into spinal features and then sacroiliac features and then extraspinal features. So with the spinal features, flowing ossifications are characteristic. So florid flowing ossification along the anterior or right aspects of at least 4 contiguous vertebrae. The left lateral aspect is usually spared in the thoracolumbar spine, thought to be due to aortic pulsation inhibiting ossification, as we discussed before. The osteophytes are largely paraspinal, with a gap often seen between the vertebral body cortex and the osteophyte. This helps distinguish DISH from degenerative marginal osteophytes arising from the end plate and from the syndesmophytes of ankylosing spondylitis, which involve Sharpie's fibers of the annulus fibrosus. So we'll come back to this in the differential again, but ankylosing spondylitis tends to produce these very vertical syndesmophytes, very fine, thin, involving the annulus fibrosus fibers. Degenerative disease tends to produce these end plate osteophytes that grow out from the end plates associated with loss of disc height, whereas diffuse idiopathic skeletal hyperostosis, you get these quite chunky paraspinal flowing osteophytes, which are also horizontally orientated, but then start to travel up and down the anterior longitudinal ligament, for example. The next point here is that disc spaces are usually well preserved in diffuse idiopathic skeletal hyperostosis. Sometimes you may have associated disc degeneration, but what you're really looking for is osteophytes and ossification that's out of proportion to the degree of disc degeneration. The next point is resultant ankylosis and rigidity of the spine is more common in the thoracic than the cervical or lumbar regions. It's frequently incomplete, and you can have interdigitating areas of protruding disc material in the flowing ossifications. The next point is no facet joint or costovertebral ankylosis, although enthesial bridging may be present. So what we're saying here is that diffuse idiopathic skeletal hyperostosis should not have costovertebral joint ankylosis or facet joint ankylosis, but you are allowed to have some bridging osteophytes or enthesophytes around the margins of those joints. So slight distinction between ankylosing spondylitis and DISH in this setting. The final point here in spinal features is that the chunky ossifications from the lower anterior half of the vertebral bodies in the cervical spine have been described as being like a candle flame or parrot beak. Definitely we see chunky ones in the cervical spine. All right, moving on to the next one, which is sacroiliac features. So no sacroiliitis or erosions are present in DISH. However, bridging osteophytes anterior to the SI joints, similar to flowing osteophytes in the spine, are common. Posterior bridging osteophytes occur, but less commonly. The bridging osteophytes may mimic joint ankylosis on X-ray. So that's important because you do get these bridging osteophytes in DISH. When you're doing an X-ray, you may see what looks like ankylosis of the sacroiliac joints, and you may be tempted to say, oh, maybe this patient has ankylosing spondylitis. It's important, though, to look at cross-sectional imaging, and you'll see that it's actually just bridging osteophytes at the front rather than ankylosis of the actual joint proper. Final little section here in the radiographic features is extraspinal features. So enthesopathy of the iliac crest, ischial tuberosities, and greater trochanters. Prominent pelvic enthesophytes are strongly associated with DISH. Exuberant spur formation in the appendicular skeleton, olecranon, calcaneum, patella ligament are frequently present. Whiskering enthesophytes is a term that's often used. And I think we all probably see these very often when we're reporting appendicular films. You'll see this prominent enthesophyte at the quadriceps insertion or the Achilles tendon insertion. And a lot of these patients will actually have diffuse idiopathic skeletal hyperostosis as an underlying cause. The final section in the imaging is the MRI, and I added this bit today. So the MRI findings correspond to those on CT. Typically, you'll have true ossification, so you'll actually have marrow signal within the flowing osteophytes. The reason why I added this section today was for this. So fat metaplasia at the vertebral corners and to a lesser degree bone marrow edema may occur in DISH, but this is less common than in ankylosing spondylitis. You probably hear about some of those MRI signs of ankylosing spondylitis. You get this edema and then you get this fatty metaplasia occurring at the corners of the vertebral bodies at the enthesis. That does unfortunately also occur to some degree in DISH, so you can't rely upon that MRI feature to distinguish between the two. If you've got, a younger patient, obviously, and quite florid marrow edema or fat metaplasia at the corners of the vertebral bodies without prominent ossifications, then obviously you're looking at ankylosing spondylitis. But if you have got these quite chunky flowing ossifications and you see a little bit of marrow edema at the vertebral corners or fat metaplasia, that's still very much in keeping with diffuse idiopathic skeletal hyperostosis. Moving on now to the treatment and prognosis. So DISH is generally managed clinically with analgesics and non-steroidal anti-inflammatory drugs where pain and stiffness are related. Managing comorbid conditions like obesity and diabetes is important. Possible complications may require specific treatment, and then we have a list of things. So, acute spinal fractures in low impact trauma. And then we have a few points related to that. Inspect the ossified ligaments for disruption and compare with prior imaging where available to discern fracture from a region of ossification. Note that fractures can also occur above or below the rigid segment due to altered biomechanics. And then it has a link to our article on chalk stick fracture. Most of us who work in the emergency departments or at a trauma hospital will know that it's really important to look hard in these patients who have rigid spines, so patients with DISH or patients with ankylosing spondylitis, and to detect these subtle fractures through the ossifications or through the syndesmophytes, because they can be very, very unstable injuries, and it may look nicely aligned on your initial CT scan, and then subsequently the patient can move and then it becomes very, very displaced. Okay, so it's important to look for very subtle fractures in this setting and to get often an MRI to look for associated ligamentous disruptions. The next possible complication that may require treatment we have listed here is dysphagia. It's reported in around 28% of cases involving the cervical spine, and it's caused by mechanical compression from the anterior cervical bone production. The next one we have here is cervical dish can make intubation more difficult, and lumbar dish can cause radiculopathy. All right, we're almost at the end of the article here. We're up to the differential diagnosis. We're motoring through. This is fantastic. That's why you should do this on your own. Much quicker. All right, differential diagnosis. So the first one we have listed here is ankylosing spondylitis. So it can be challenging. Often, ankylosing spondylitis looks like ankylosing spondylitis and dish looks like dish. But there are cases where you go, the osteophytes, syndesmophytes aren't that chunky. Some of them are a little bit thin, and you may be considering one versus the other. Age is important. Obviously, ankylosing spondylitis tends to present at a younger age, dish at an older age. In terms of the ossifications or calcifications themselves, so the syndesmophytes in ankylosing spondylitis are thinner, and they form over that annulus fibrosus, and they're vertically oriented, and that's what produces the bamboo spine. So you don't get too much of this chunky ossification in ankylosing spondylitis. Ankylosing spondylitis also causes a true sacroiliitis involving the synovial joint, so the inferior 2/3 of the joint, with erosions, adjacent marrow edema, fat metaplasia, and eventual intra-articular ankylosis, as opposed to para-articular bridging osteophytes, which is what we see in dish. And then the final point we have here is that osteoporosis is prominent in ankylosing spondylitis. The other tip would be to look at those other joints like the costovertebral joints and the facet joints to look for ankylosis there, but remembering the dish will also sometimes cause those marginal osteophytes that kind of simulate ankylosis. The next on our list of differential diagnosis is degenerative spine disease. So in these patients, you'll see disc degenerative changes, obviously, with disc height loss. The osteophytes will arise from the end plates rather than from the anterior cortex or in a paraspinal location, which is what we see in dish. The anterior longitudinal ligament is uncommonly ossified in degenerative disease alone. So if you're seeing ALL ossification, it's unlikely to represent degenerative disease. And the final point we have is that prominent facet joint degenerative changes will often accompany degenerative disc disease, so look for that. Just a few more differential diagnoses to discuss, and they're obviously far less common than these first two. We have retinoid arthropathy. So this is patients using retinoic acid for skin diseases. They can get skeletal hyperostosis, and that predominantly involves the cervical spine, so that's worth thinking about. The next one we have listed is fluorosis. So fluorite intoxication due to long-term ingestion that can cause paraspinal ligament calcification. But remember, they will have often accompanying osteosclerosis or at least trabecular blurring and haziness in the bone. So there'll be other signs to suggest fluorosis in those patients. That reminds me of a story, actually. We had a patient quite a few years ago now who presented, and on their imaging, they had features of osteosclerosis. And it turns out it was due to fluorosis. And the only thing they could think of as the cause for the patient's fluorosis is that they were addicted to Penthrox, the methoxyflurane, the green whistle analgesia that people often, that's what we call it in Australia anyway. So this person was addicted to that, and it was thought that maybe that was producing too much fluoride and resulting in their fluorosis. Anyway, I'm not sure that was 100% proved that was the mechanism, but it's interesting to think about. The final comment we have here on the article is if seen in a child, so I assume, if you're seeing paraspinal ossifications, consider juvenile idiopathic arthritis. And that's it. We've made it to the end of our diffuse idiopathic skeletal hyperostosis article. I'll leave it there, and no doubt Gaylard and I will have a little chat in the outro. Well, he's done it again, hasn't he? We were just talking about skilled narration in the intro, Galen. You just had a perfect example of it. I'm sure you were transported to a world of chunky calcifications and osteophytic delights there.
It's like I was there, Dixon. In fact, as I listened, I got all excited because I thought I could bring up my personal brush with eagle syndrome. But then I realized, thanks to a quick search on our transcript, that I've already told that story. So in episode 34, it was. I won't tell it again here.
Yeah, it was a good episode, that one.
It
So
was.
it was all about patient experiences with Sue Robbins. It's actually one of my favorite episodes. So if people haven't heard that one, I would recommend going back, giving it a
Mhm.
listen. Long story short, though, you've got impressively long styloid processes, right? I think
Mm,
you've made a 3D render of it at some point. Did you
of
put that on the
course.
website in the end? And more importantly, do you have Dish, mate?
I think I have uploaded it. I'm not sure whether that violates patient confidentiality. I guess it's mine and I'm giving
Yeah,
consent. So,
yeah.
yes, and they're both very impressive. They reach all the way down and the right one has this nasty hockey stick shape that digs into my pharyngeal wall.
Mm.
It has been fortunately asymptomatic now for quite some years, having stopped poking at it
Yeah,
and
stop
wondering why
poking
it
it.
occasionally
Yeah.
hurts. But I don't have dish, at least not in my cervical spine. I'm not sure about elsewhere. I don't have OPLL either, but I haven't had my thoracic or lumbar spine imaged. So, one thing that it made me think of after I've had various bits and pieces scanned,
Mm.
including my head and neck and brain.
Put
The
them all
brain,
on the website.
I should put them all. The brain was for some research thing. But you know what's annoying? If you find a medical condition and then you try and get life insurance or health insurance, then it either gets excluded or your premiums go up.
Yeah.
But if you do a scan and there's nothing wrong with you, your premiums should go down. You're at lower risk, but they don't.
No. It's interesting. I remember hearing, and I'm not sure whether this is true, but I remember hearing that people who ride motorbikes are
Mm,
statistically safer car drivers. So they're involved in less car accidents
mm.
because they have a better road sense because you've got to be hyper alert when you're on a motorbike. But being a motorbike rider doesn't reduce your car insurance premiums.
Yeah,
Yeah. So they're
yeah.
not allowed to really discriminate based on that, apparently,
Nothing
which is
seems to reduce your premiums,
no,
only make
no.
your premiums go up.
The winner is the actuary. Now, do you have anything to say about Dish itself, Gaylord?
Well, I put dish in that group of diagnoses that radiologists get really excited about when they start doing radiology and they find out all these diagnoses that they'd never heard of before, along with, I don't know, osteopoikilosis and hyperostosis frontalis interna. And they seem to be over included in reports. So maybe that idea of limiting it to when it's only, what was it, 4 vertebral
Hmm.
bodies? That's probably a useful rule, I reckon.
I don't think you can lump Dish in with hyperostosis frontalis interna. I mean, that's completely incidental and benign. Although maybe it's related to Dish. Has anyone done that study? Is there an
Ah.
association? But Dish carries an actual risk, right?
Hmm.
In my experience with radiologist reports, I think sometimes that background badness in someone's spine is often overlooked
Yeah,
or
absolutely.
underreported. The C-spine report just says no fracture or traumatic malalignment, and often maybe just a token comment about the degree of degeneration.
Yeah.
I reckon we almost need like a scale for communicating how fused or rigid a spine is, irrespective of whether it's dish or some degenerative ankylosis or actual ankylosing spondylitis, because it's that mechanical rigidity that really
Mm.
carries the risk and what we need to kind of convey in the reports. Drawing attention to it might actually change the patient's behavior in the future. They might not get involved in any risky activities that could cause a fracture, or if they are involved in a low impact trauma, they may not ignore it. Like, I've seen ones where they present days after a minor injury with a gaping fracture, opening
Yeah.
like the mouth of a muppet, because they've got underlying
Oh, the Muppet
dish.
sign.
Yeah, not the carrot stick or the chalk stick, the muppet fracture. And then I've also seen cases where the CT finding is very, very subtle, and only in retrospect do you see it. And the
Mm.
MRI shows a 3-column unstable injury. And if you don't comment on that degree of rigidity or fusion on the CT, they might not go on and get the MRI. So you kind of need to factor that into adjusting your threshold for proceeding to MRI. So I don't know, I think reporting dish, in my experience, underreported, and we should probably be mentioning it when it's there because it
Yeah.
is of significance, unlike hyperostosis frontalis interna, which just sounds cool.
Yes. Now, I think that's a good point. The other thing that I think has just occurred to me now while you're talking about this, the spine is a little bit unique in that we feel it's okay to completely ignore it in certain circumstances.
Hmm.
So If you're doing a CT abdomen and pelvis for, appendicitis or diverticulitis or something, and there's rip roaring degenerative change
Yeah.
and canal stenosis, like, oh, they didn't ask about that. I'm just going to say nothing, or just some vague multi-level degenerative change. But in other organ systems or regions, if the question is diverticulitis, you don't just ignore the kidneys.
No.
You kind of report them. And it's because it's tedious and boring to report degenerative change.
Yeah.
But if we do it properly, when people go back later, you can avoid a lot of scans because, in fact, it's been imaged before.
That reminds me of a thought I had recently with a way you could do AI in the future would be, the patient could go, I just want the AI to look at my kidneys, and you're
Yeah.
not paying for liver
Yes.
or spleen or pelvis or
And it
spine, right?
blacks everything else out.
So it tells you, you've got this thing in your kidney, and then it goes, would you like an add-on? The image is
Ooh.
already there, but would you like me to analyze your spine as well? Pay an
Ah.
extra
Well, I mean, that's how
$22.
AI companies are trying to pitch their products, though, because none of them does everything. It's like, oh, you buy the brain hemorrhage detection package, and then do you also want to detect lobar pneumonia? Because that's a separate thing.
I reckon the general ones are coming though. I reckon it
Yeah.
won't be far away.
I was also interested in the associations that you brought up, because enthesopathy elsewhere, that's interesting to think about. It's not often included in the field of view of when you see these, right? I mean, maybe I suppose in a CT abdo-pelvis, you'll see the pelvis, but you're not seeing olecranons and
Yeah.
peripheral axial skeleton.
I don't think it's that important in the context of spine imaging. You've already got the spine. But I think if you're the other way around, like you're looking at a pelvis or knee or ankle, and you see a patient has lots of enthesophytes, perhaps they do have dish, and perhaps spine imaging is
Hmm.
indicated. I don't know. We don't want any more spine imaging indications, actually. So
No, and you wouldn't treat dish on its own if it's asymptomatic, right?
I do wonder, though, in the future, there could be a disease modifying treatment for
Hmm.
dish, like, for spondyloarthropathies, and therefore, if early detection becomes a more useful thing. Because it just seems like something that, it'd be great to be able to slow the progression of,
I mean, having parts of your body ossify when you don't want them to doesn't sound like a good thing. We should not have that.
especially if you're tempted to poke that area.
Yeah, it's associated with OPLL. OPLL is no good. You
Yeah,
don't
yeah.
want that.
No good. That's a subsequent solo readful, maybe.
Yes.
You mentioned the associations there, so OPL, metabolic syndrome, and the ossification of the styloid ligament. And it reminded me of something one of my trainees said to me just the other day. So he's just sat the RANSCA Part 2 oral exam, which is known as the OSCA exam. And he commented that maybe Radiopaedia inadvertently has made radiology exams harder, because he reckons
Ow.
examiners go, right, I've got a case of dish. All right, we'll give that to the candidates. And then they go, all right, I've got to write these related questions. Okay, go to Radiopaedia. And then suddenly they're asking, what are the diagnostic criteria for dish? List 3 known associations of dish.
What
Has
slightly famous radiologist has Eagle syndrome?
It's an interesting debate, though, isn't it? Has Radiopaedia made radiology exams easier or harder?
Boy, I'd never thought of that. But generally, multiple choice questions that include associations are always terrible, because in so many conditions, the associations are really vague or seem to be haphazardly chosen out of case reports or whatever. So, if I asked you, is Cowden syndrome associated with increased risk of, I don't know, testicular cancer? How would you answer? And it's like, well, I know it increases tumors, but I don't know about testicular cancer. And you go to the website, to Radiopaedia, I've just looked at it now, and testicular cancer is not one of the ones that's listed. So if you created your multiple choice question, would you mark that one as a false? But in fact, if you then look at case reports, there are certainly case reports of testicular cancer in so I don't know. If people are relying on not just Radiopaedia, but on anywhere to look for associations in their questions, they should be ashamed of themselves, and it's not our fault.
From what I've seen, that's exactly what the examiners seem to do. They seem
Oh,
to look at this esoteric kind of stuff. But I don't think he was necessarily referring to MCQs in this instance. So this is like an oral exam where the questions are, you've got to list things off your own
like
bat.
what associations does
Yeah.
NF2 have?
Yeah. So you
Yeah.
kind of just have to know them, or at least have a stab and make up some.
I would hate to think that we're making things harder.
Yeah.
I wouldn't be surprised if examiners or question writers use our articles.
No.
That's for certain. And there's also, I see it with my youngest son, who's now, I shouldn't be hesitating, 11. He's just started playing Dungeons and Dragons, and he takes great joy out of creating situations where the characters that are playing with him, and he's playing as dungeon master, they're just going to die. And it's like, no, that's not how this is meant to work. And I think exams are the same. If you're writing questions where you're trying to trick or fail candidates, it's really easy to do that, but that's not meant to be the point, especially because it distorts how people then study for exams.
That's my concern. If these are the kind of questions they're getting, list 5 associations, it steers them towards learning those kind of things rather than actually getting great at image interpretation and running MTTs and things like that.
Yeah.
Just quickly, one more thing, and that's with regards to the solo readful itself, Gaylard.
Mm-hmm.
I can't help myself but occasionally say random things when I'm reading out the text, like the green whistle part.
Yes.
But when there's no one there to chat with, it doesn't really go anywhere. So you just kind of like just leave it out there hanging.
If I was there, I would have told you about the time I watched my wife use a green whistle.
Yeah, see?
We were skiing and she snapped her tibia and fibula over the top of her ski boot, and her leg was bent at 90 degrees mid-shin where it shouldn't be. And
not at the knee.
Not at the knee, at the knee as well. But she wasn't, not great at that point. She was pretty much delirious with pain. And then the ski patrol came up and gave her the green stick, and she took a couple of puffs with it. And within, I don't know, half a circulation time of her blood, she was like chatting with the ski patrol, asking her how her day was going, la, 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 la. It was amazing. And I'm pretty happy that we don't have them lying around. And I'm pretty happy that I'm not an anaesthetist, because I think I'd have a lot of trouble resisting the urge. A little bit for you, a little bit for me.
Well, that sounds like the perfect time to wrap up this episode then. Gaylard, how can people get in contact with us?
Well, we're at Radiopaedia on X and Instagram, as well as at Frank Gaylard and at Dr. Andrew Dixon. Or you can email us at podcast@radiopaedia.org with any ideas and feedback, or maybe some, links to where we can get some black market green sticks.
Now, next episode, Gaylard, will actually be our 2-hour special edition, as I mentioned earlier, for the conference. So the release date's going to be a little bit different because it'll be day 5 of the conference. So maybe we'll put out like a little bonus mini episode on day 1 of the conference, and then we'll hold off that proper episode until day 5. So people will just have to wait, but it'll be worth it. But you won't actually be waiting anyway, because surely most of our avid listeners, Gaylard, will be attending the whole virtual conference anyway. So they'll be interacting with us in the live chat all week.
Yep, absolutely.
Now, shall I read this text little bit still? If you want to help support Radiopaedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and conferences in 2 weeks' time. As I said, in doing so, you'll be helping us to give free conference and course access to people in 125 low and middle-income countries. And what else can people do to help us out, Frank?
And you can also help us out by leaving a 5-star review in the podcast app of your choosing.
And we'll catch you all again sometime soon, slightly delayed because of the conference, in the reading room.
Stay rad and see you at the conference.
Yes, we'll see you there. Looking forward to it.
Absolutely. Bye.
Bye.